I'm Dan. I'm dual training in emergency medicine and intensive care medicine, and I was asked to deliver a talk of kind of a emergency intensive care focus, and I thought one of the areas of interface is often toxicology, and so I thought I'd try and give a talk around toxicology with a relevance to critical care. So I'm planning to go through a bit about why it's important, cover the approach to the poisoned patient, review some of the classical or the important toxidromes. I'll look into a few of the specific poisonings it's worth knowing about and run through some of the common antidotes. Just jump in and stop me if there's any questions or comments. My technology seems to be letting me down, so hopefully it will get through it. So first I want to kind of talk about why it's important and worth knowing about. Unfortunately, this is a fairly standard site outside the emergency department at the moment, and it's kind of just there to illustrate that, you know, a number of these ambulances are going to be bringing in poisoned patients. Self-poisoning is common, and some of these patients who come in, the vast majority don't require critical care. Some end up in resus, and then some of those do require level 2 or level 3 care. It's estimated about 1% of NHS admissions are due to poisoning, and I know that I've been called down to resus, and I'm sure most of us have been called down to resus to review patients following accidental or deliberate self-poisoning. It's a major health problem worldwide. It's a common reason for young people to be admitted to hospital and to critical care. Unfortunately, the UK has one of the highest rates of deliberate drug overdose in Europe, and the vast majority of patients, as I say, don't require critical care, recover well with simply a period of observation and supportive care. But they do present a reasonable burden on intensive care units. There isn't a huge amount of published epidemiology, but one study I found from Edinburgh, they published pre-COVID, and they had about 120 admissions a year for their unit requiring level 3 care, which is about 1 every 3 days. So it's important, it's common, and it can be serious, tends to affect younger patients, and it's often reversible. So I just wanted to kind of start off by talking about the Toxbase, which I'm sure everyone's aware of. It's a great resource. You can put in almost anything that anyone may have taken or been poisoned with, and it will give you a simple step-by-step management instructions. It's run by the National Poisons Information Service, and in the case of significant, unusual or multiple agent poisonings, you can ring them. They're available 24/7. You can speak to a clinician and get individual advice for your case. There's 4 units. There's one in Birmingham, one in Cardiff, there's one in Edinburgh, and then another in Newcastle. Each unit has a consultant clinical toxicologist and then other specialists and nurses who work in poisons information, and they provide a kind of service so that they're always available, and it's been running for about 50 years, and it is really useful. So I wanted to move on and look at your approach to a poisoned patient. This picture shows one way to do it, although thankfully not the way we usually have to employ. This was people investigating the Novichok poisonings in Salisbury. Thankfully, that sort of poisoning is less common, and we don't have to put those suits on. We don't even have to wear those for COVID patients, so that's good. Approach to a poisoned patient is fairly simple, and it's very similar to the standard approach for any critically ill patient. Poisoning is often multi-system, but assessment and resuscitation follows a standard algorithm, obviously airway, breathing, circulation, and all the rest of it. Initial measures should obviously include control of seizures. A lot of these drugs and poisons can lower people's seizure threshold, correction of hyperglycemia, hypoglycemia, because they do affect your glucose metabolism, and hypothermia. A lot of these patients will have deranged temperatures. And then it's worth considering toxidromes and the different antidotes. I'll have a look at those in a bit. And then following that, it's mostly supportive care, and then there are some investigations, both screening and specific, that you can send off, and that's usually guided by the history. We don't often need to decontaminate patients, but it is worth considering decontamination if they think that's kind of indicated from the way they're presenting. And then looking at enhanced elimination, and then what you think the clinical course is going to be when you see that patient, and how you think they're going to respond going forwards, and then what level of care they're likely to need. In the case of cardiac arrest in a setting of a suspected poisoning or a poisoned patient, the NPIS usually suggest a prolonged resuscitation time of at least an hour. It says that in a lot of the tox base informations for the various poisonings, and that they say that because a lot of these patients, they find that even with prolonged resuscitation, if the arrest was due to poisoning, they go on to have a good recovery. So they usually say about an hour. And with the poisoned patient, it is always worth bearing in mind that they may continue to deteriorate after their arrival in the emergency department or from when you first see them from a critical care perspective. Delayed action poisons include things like aspirin, iron, paracetamol, tricyclic antidepressants, and obviously modified release preparations will also give a delayed picture. So this is a fairly busy slide, which is just to introduce us to toxidromes. In the unconscious, altered or challenging history from a poisoned patient, it's always worth having in the back of your mind as part of your approach to a poisoned patient. This kind of breaks it down into eye responses, whether they've got a dilated or constricted pupil, and then whether they're sweaty and what their muscle tone's like. And we'll look at some of the toxidromes in a bit more detail. Toxidrome's just a portmanteau of toxic and syndrome that somebody in the 1970s came up with, and we liked it, so we carry on talking about them. In theory, it is a lovely way to identify what your patient may have taken and how best to treat them, but often in practice there's co-ingestion, there's patient factors, and there's other things that may mean that they don't fit into that textbook definition or toxidrome, but it is useful, as I say, to have in the back of your mind because patients will exhibit at least some of these features, and it can help you guide your management. So the first toxidrome I wanted to talk about was sympathomimetic toxidrome, and some of the features are shown on this cartoon. It's caused by drugs that have an activating effect on the sympathetic nervous system through direct or indirect effects on catecholamines. Common causes we see in ED for this are cocaine and amphetamine use, and the patients are your typical hyperadrenergic fight or flight state. They can be tachycardic, tachypneic, hypertensive, febrile, they'll have dilated pupils, they might be sweaty, and they'll have normal muscle tone. They tend to be hyper alert or agitated, but they may be hallucinating, and they'll have some degree of tremors or hyperreflexia, and they may progress on to seizures. In patients who are exhibiting sympathomimetic toxidrome type state, it is worth remembering to avoid beta blockers. In some of these patients, if you give them beta blockers, you then get an unopposed alpha receptor stimulation, which can cause uncontrolled hypertension and vasoconstriction. Treatment in sympathomimetic toxicity is supportive care, as with most, as you'll see, with most toxidromes. They often require IV fluid. They may have a degree of rhabdomyolysis. Benzos are often useful for anxiety, agitation, and also for coronary vasospasm and helping with chest pain. If it's severe, they may require rapid cooling, and they may require short-term agents to manage hypertension. Short-term, you don't want to give them something longer acting because once it starts to wear off, then their blood pressure may be the other way. This differs from the anticholinergic toxidrome, which I'll talk about next, because these patients are sweaty and they have normal bowel sounds. But as I say, these are useful to have in the back of your mind, but not an absolute way of looking at patients and categorizing them. So I think a lot of people have heard of the anticholinergic toxidrome, the dry as a bone, red as a beet, hot as a hare, blind as a bat, mad as a hatter thing. But basically it's caused by drugs such as antihistamines. Tricyclics can cause an anticholinergic toxidrome. Anti-Parkinson's agents, antispasmodics, phenothiazines and atropine will cause an anticholinergic toxidrome. It's similar to sympathomimetics. They'll be tachycardic, tachypneic, hypertensive, febrile. They'll have dilated pupils, but they're more often not sweaty, and they can have absent bowel sounds and urinary retention. They're often confused and less alert as a contrast to the sympathomimetic toxidrome. Treatment of these patients is supportive again. Fluids, they'll often require catheterization. They may require cooling and benzodiazepines. You can give them neostigmine as a cholinesterase inhibitor, and that will help inhibit the breakdown of acetylcholine, which is implicated in this. Consideration of patients for these is thinking about activated charcoal. It's often given, I'll talk about it later on, but with these patients it's worth checking if they've actually got bowel sounds, because if they've taken something, given them an anticholinergic toxidrome, and they haven't got bowel sounds, then giving them charcoal is unlikely to be of any benefit. Then Moving on to another cartoon showing us the Hypno sedative toxidrome. This is a really common one presenting to ED, and these patients can sometimes require a short stay on intensive care. It's classically alcohol and then co-ingestion with benzodiazepines or some other GABA agonist. Patients will be amnesic, confused, ataxic. They may have nystagmus. They often lose bladder control. They can be hypotensive, bradycardic, hypothermic. Helpfully, their pupils are either enlarged or constricted, so it doesn't always fit into that nice flow chart. But these can progress into decreased conscious level and coma, requiring airway protection. Management supportive, always flag up that even if they've taken benzodiazepines, you should avoid flumazenil because it can precipitate intractable seizures, especially if the patient chronically uses benzodiazepines. Then the next toxidrome is opiates. Common cause of presentation to the emergency department. It may require critical care input, especially if it's not been identified by the treating ED clinician. Typical scenarios: a somnolent patient, altered mental status, slow respiratory rate, bradycardic, pinpoint pupils, but it can be less obvious, especially patients who might be on chronic opiates with a new renal impairment who present with reduced GCS. In those cases, it's not always apparent or identified, and it's worth wearing patches. Some patients will have patches on for pain control. And it's always worth fully exposing and examining patients, especially if they've got reduced GCS and you don't quite know why. Is obviously with naloxone, but there are some nuances to be aware of. Naloxone lasts for about an hour to an hour and a half, but many of the substances patients have ingested will last longer than that. And so that's why we admit patients for naloxone infusions. And we talk about the dose of naloxone given should be aimed to reverse their respiratory depression and ensure that they're protecting their airway, but not fully waking the patient. These patients often don't like you when you wake them up fully, giving them naloxone after having taken opiates. They can be challenging to manage, agitated, aggressive. They may be a danger to staff, they may self-discharge, and then the short half-life of naloxone will mean that they could end up in the same state once that wears off. So it is worth kind of titrating your naloxone to reversing respiratory depression, but not just giving them a big whack and trying to wake them up, because then you just cause yourself more problems. And another thing to flag up is that in cardiac arrest, naloxone is not a priority. In these patients who have arrested following opiate overdoses, that's usually airway obstruction, respiratory depression or hypoxia. And by the time that they arrest, it's too late for the naloxone to fix that. Good quality advanced life support should be your priority, and naloxone isn't going to give them a ROSC. You need to get them back first. And then this poor chap's got a cholinergic toxidrome. So this is classically organophosphate poisoning, but it can be Alzheimer's medications and then some mushrooms that odd people may go out and pick and eat. They predominantly get muscarinic symptoms. They have miosis, bradycardia, hypersalivation. They get sweaty, nauseated, they vomit, they have diarrhea, bronchospasm, they become incontinent and confused, and they may progress on to having coma, seizures and death. It's caused by an increase in cholinergic stimulation, and then organophosphates and cholinesterase inhibitors cause an increased amount of acetylcholine, and then pilocarpine and some toxins from mushrooms are cholinomimetics. They work in a similar way. Treatment for these is decontamination. Is important to remember in people who present with a cholinergic toxidrome, especially if they've been exposed to organophosphates, and then supportive care, as I've said over and over again. The killers with somebody who's got a cholinergic toxidrome are often bronchospasm and bronchorrhea, so secretions and bronchospasm will be the problem. And patients who present with a cholinergic toxidrome, it's worth giving them atropine. That will help with the management of their respiratory symptoms. And then paridoxamine will help with their neuromuscular manifestations. Also, they can have benzos, which will help with seizures. There's two mnemonics to kind of make you think about cholinergic toxidrome. There's either sludge or dumbbells. Sludge is salivation, lacrimation, urination, diarrhea, gastrointestinal distress and emesis. It's all lovely, really. Or dumbbells is diarrhea, urination, miosis, bradycardia, emesis, lacrimation, lethargy and salivation, if they help you remember it. Then moving on from kind of your classical toxidromes to look at the syndromes that I think it's worth flagging up. There's two important toxicological syndromes I want to cover. Firstly, serotonin syndrome, and then neuroleptic malignant syndrome. Serotonin syndrome, firstly, is a constellation of symptoms caused by increased CNS serotonergic activity. So drugs that can cause that are your SSRIs, tricyclic antidepressants, monoamine oxidase inhibitors, triptans, lithium and cocaine can also cause the serotonin syndrome, among others, and it does flag up things that are serotonergic in tox space, and talk about that on a lot of these ones that patients might have ingested. Predominant symptoms are cognitive, autonomic and neuromuscular, and patients who are on serotonergic drugs who present with kind of anything about confusion, agitation, coma, hypothermia, tachycardia, hypertension, hyperkinesia, hyperreflexia or myoclonus. It's worth having it in the back of your mind if they're presenting with those features, because it's obviously very serious. They also tend to have a cogwheel type rigidity. And it's fatal if not effectively managed. Treatment supportive, airway support, IV fluids, benzodiazepines, cooling, as we talked about. They may require muscle paralysis if they're hypothermic. Hypertension should be managed again with short-acting agents. People have talked about dantrolene before for reducing muscle rigidity and subsequent heat production, but dantrolene's been implicated in causing serotonin syndrome and hasn't shown to have any survival benefits. They tend to avoid it in serotonin syndrome. And then there's cyproheptadine, which is a antihistamine, but it has some anti-serotonergic properties. So it's an oral medication that's sometimes recommended by Toxbase, and I think we do have it. The next one's neuroleptic malignant syndrome. It's severe, it's life-threatening. It's usually characterized by a tetrad of autonomic instability, altered mental status, hypothermia, and muscular rigidity. And it can occur at therapeutic doses of antipsychotics. It doesn't have to be overdose, and it may progress rapidly. It's thought to be triggered by dopamine blockade, but it can also be precipitated by abrupt cessation of dopaminergic drugs in Parkinson's disease. Patients are hypothermic, hypertensive, tachycardic and tachypneic with an altered mental status. And in contrast to the serotonin syndrome, they tend to have a lead pipe rigidity rather than cogwheeling. It's got quite a wide differential diagnosis, as you can imagine, but it is worth considering early in patients who are on antipsychotics. It's supportive care again, but making sure you stop the antipsychotics. They often require airway support, IV fluids, rapid cooling, benzodiazepines, and in these patients you can consider dantrolene to reduce their muscle rigidity and heat production. Then moving on from the syndromes, I just want to look at a few specific poisonings that have some relevance to us. The first is one of the most common self-poisonings we see in the emergency department, which is paracetamol. I'm not going to go too much into the detail of paracetamol poisoning. Often it doesn't require intensive care, and when patients are critically unwell, they're often transferred to a liver unit for consideration of transplant. But patients may present to us with co-ingestion, including paracetamol, and it's something that we can test for. It's worth remembering to take the paracetamol levels 4 hours after they've presented to hospital, especially in unconscious patients. Their levels may continue to rise if they've taken something just before they've come in, and then they've been brought in. A paracetamol level at that time might be falsely low, so it is worth bearing in mind, especially in unconscious patients with an unclear history. It's also worth knowing that since the SNAP protocol has been published, most hospitals have moved over to that regime. It's giving a 2-hour bag of NAC and then a 10-hour bag of NAC, rather than the kind of historic 21-hour regime of 3 bags. It's the same management at the end of the infusion, checking their INR, ALT, creatinine and a VBG. And then if things haven't resolved at that point, then it's repeating the 10-hour bag until they do, unless they meet the criteria for referral to a liver unit. But it's just kind of worth flagging up that that's been a bit of a change in management recently. And that protocol on the left-hand side of the slide is just our local hospital guideline for what happens after they've had their initial NAC treatment. Next specific poisoning I wanted to talk about was salicylate poisoning. It's less common, but it's important to be aware of. It's another poison that we can quickly test for along with paracetamol, and a lot of patients who come in unconscious will get a paracetamol and salicylate level sent Typically, it presents with a respiratory alkalosis and a metabolic acidosis. Patients may be vomiting, tachypneic, they may have tinnitus, they may be confused, they can go on to be hypoglycemic, develop seizures, pulmonary edema, and coma. They get direct stimulation of their central respiratory receptors, which causes their hyperventilation and then their respiratory alkalosis. And they also get uncoupling of the oxidation phosphorylation system, which contributes to their metabolic acidosis, as well as a bit of compensation for the respiratory component. Treatment for aspirin and other salicylate poisonings is in the mainstay supportive. Intubated patients could be hyperventilated to counter some of the acidemia, and sodium bicarb is given for urinary alkalization. That's a way of enhanced excretion. It means that the salicylates are excreted more effectively and quicker by the kidney, and you should aim for a serum pH of above 7.4 and a urinary pH of between 7.5 and 8.5, which you can measure. And then in severe poisoning, renal replacement therapy is indicated because it does clear salicylates. And just to kind of highlight there, I thought it might be reasonable to mention the toxins that can be cleared by hemofiltration. So it's good for clearing small non-protein bound toxins. So that includes salicylates, as I mentioned, but also the toxic alcohols, so ethylene glycol and methanol. Lithium, theophylline, valproate and metformin, but it doesn't clear the other toxins that they may present with. And so in that setting where it's not one of those, then it's just the normal indications for renal replacement. Then moving on to another poisoning that I think is worth knowing about is sodium channel blockade. So this ECG is sinus tachycardia, broad QRS, and it's taken from a patient who's taken a tricyclic overdose. Tricyclics are one of the most widely discussed sodium channel inhibitors that presents in overdose. Thankfully, people aren't on tricyclics that often anymore, tend to be on SSRIs, so it's less common, but tricyclics have several physiological effects. They have sodium channel blockade. They have anticholinergic activity, so you can get that anticholinergic toxidrome we talked about. You get blockade of peripheral alpha receptors, so they get vasodilated. You get a central antihistamine activity, which makes them somnolent. You get GABA antagonism, which may lower their seizure threshold. It causes lots of issues, basically. There are other drugs that interfere with your sodium channel. So citalopram, fluoxetine, venlafaxine are all antidepressants that will cause a degree of sodium channel blockade. Some antiarrhythmics, including flecainide, will cause it, and propranolol is a beta blocker that causes sodium channel blockade, along with some antihistamines, some antiepileptics, and cocaine. But often the overdose effects of tricyclics will get better with supportive care, but cardiac sodium channel inhibition is often their greatest life threat for them. So the management of that is with sodium bicarb. Indications for bicarb in a tricyclic or sodium channel blockade overdose are if they're fitting, if they've got a ventricular arrhythmia, or if they've got a prolonged QRS, or if they're hypotensive despite fluids. Initial loadings usually with 50 to 100 mils of 8.4%, and then they may go on to need maintenance. You're aiming for a normal QRS, although that may be impossible if they've got a broad QRS or it's severely prolonged. You're aiming for a moderately elevated pH of about 7.5, but it is important if you're giving somebody bicarb in this setting to avoid excessive hyponatremia, and it may also precipitate hypokalemia and hypocalcemia, so it's important to keep a close eye on electrolytes. Bicarb's thought to work because the high sodium content of bicarb increases the function of cardiac sodium channels. Increasing the pH may decrease the binding of some agents to the sodium channel, and increasing the pH also reduces the free drug concentration in some of these situations. If you get a patient who has taken a tricyclic or another sodium channel blocking agent who has an intractable arrhythmia despite bicarb, including VT or VF, then you can give them IV lidocaine. Lidocaine is a bit counterintuitive because it binds and blocks sodium channels itself, but it blocks them in a slightly different way, and it competitively inhibits them, so it actually seems to help. If they're refractory to that, then you can look at intralipid as a kind of lipid rescue therapy, which shuttles some of them away, but it's a bit of a last-ditch hope. Then Another specific poisoning I just wanted to highlight, because it's one I saw fairly recently, is cyanide poisoning. So it's less the kind of spy pill, suicide capsule, but definitely something to consider in house fires, firefighters. It's released from burning wool, silk, insulation, particle boards or rubber, and it's worth considering in people brought in from house fires or brought in for carbon monoxide poisoning who are a little bit more sick than you might expect. It's worth considering if a patient's got a persistent lactemia more than 10 despite resuscitation and an anion gap acidosis. I saw a patient who was brought in under arrest by the police, having been dragged from a house fire that they were thought to have caused, who was unconscious with a raised carboxyhemoglobin, who's been treated with high flow oxygen, but he wasn't waking up. He had a raised lactate despite a load of fluid, and the treating team was suspecting co-ingestion of alcohol or something else, but hadn't considered cyanide poisoning in that chap. Treatments with hydroxycobalamin, which scavenges cyanide, or then sodium thiosulfate. Moving on again, I wanted to touch on beta blockers and calcium channel blocker toxicity. First, looking at beta blocker toxicity. These present, as you might expect, with bradycardia and heart blocks. They can be hypotensive or dysrhythmic and have an altered mental status with changes to their QRS or QT interval. They may be hypoglycemic. Most beta blocker overdoses are benign. There's two that require special consideration. Propranolol, as I said, has effects on the sodium channel. They can get a prolonged QRS in addition to the other features, and they should get some bicarb. And sotalol causes a potassium efflux blockade. They will develop long QT, so they need to be monitored for torsades, and they may need magnesium. IV glucagon is the one that people know for beta blocker toxicity. Tend to give them 5 to 10 milligrams as a bolus and then an infusion. The other therapy that's used is high dose euglycemic insulin therapy, which I'll talk about in a bit, and those are useful if they're refractory to kind of normal supportive care. Then calcium channel blocker overdose. These again present with bradycardia, heart block, hypotension. They may have some nice other features like constipation, ileus, nausea and vomiting, and they may be hyperglycemic, whereas the beta blocker overdoses can be hypoglycemic. Most lethal calcium channel blockers in overdose are verapamil and diltiazem. They bind to part of the calcium channel, which prevents intracellular calcium influx, and those are most important in cardiac myocytes and smooth muscle, as well as they have some effect on the pancreatic beta cells. So they get kind of cardiac toxicity even in kind of more benign calcium channel blockers like amlodipine. In large doses, then you can get quite significant cardiac toxicity and effects on smooth muscle. They also get metabolic derangement. They will get hyperglycemia, hypoinsulinemia, and it's a bit, it's not good. Initial treatment again is supportive, but they may improve with IV calcium. 20 mils of calcium chloride or 60 mils of gluconate can be repeated 3 times. An infusion can be given, and again in calcium channel blocker overdose, high dose insulin therapy may be considered, and they may need pacing, bicarb or intralipid. Talking about high dose insulin therapy, I've mentioned it a couple of times. It's useful for beta blocker and calcium channel blocker poisoning. High dose insulin therapy allows the heart to overcome the metabolic starvation resulting from those poisonings. The effects of the insulin are kind of manyfold. It increases your glucose and lactate uptake by myocardial cells, improves your myocardial function without particularly increasing the oxygen demand, increases your pyruvate dehydrogenase activity, hastening myocardial lactate oxidation, and it kind of has lots of features, as well as having excess glucose around helps enhance calcium entrance into the mitochondria and increases your cytoplasmic calcium concentrations. So it works when you've taken a beta blocker or a calcium channel blocker overdose, and helps with your cardiac function to reverse some of the cardiotoxic effects. Obviously, the adverse effects of high dose insulin therapy are hypoglycemia, and then hypokalemia, hypomagnesemia, and hypophosphatemia. So this is one of the protocols. This is from Life in the Fast Lane, the online their website, but there are protocols on Toxbase as well. The evidence is pretty good for it, and it's been shown to be superior to glucagon in beta blocker poisoning, but it is risky. I think in some of the studies, at least kind of 15-16% are having significant hypoglycemia, and it makes people a bit unhappy giving such high doses of insulin, and requires obviously very close monitoring. Now I just kind of wanted to run through some of the antidotes that we have when you're considering toxicology. As I say, a lot of care is supportive, and that's the mainstay of management, but we do have some specific antidotes. This list comes from the Royal College of Emergency Medicine and the National Poisons Information Service, and all of these drugs should be available in resus. So it's the ones you'd expect, including management of cyanide poisoning with the different medications there. Flumazenil, as I said, is something that really should be used in caution and shouldn't be used in a kind of mixed overdose, or it's usually just iatrogenic oversedation that should be used for. Glucagon we've talked about, intralipid as your rescue therapy, methylene blue, procyclidine, all of these should be available immediately in resus. And then these drugs should be available in the hospital. That's the standard as well. So cyproheptadine, which we've talked about, some other specific antidotes, calcium folinate in methotrexate overdose, fomepizole in toxic alcohols, desferoxamine in iron overdose. And interestingly, it notes that you've got to have macrogol, so Movicol or Laxido, and we'll talk about that in a minute. And then I just wanted to talk about charcoal. Activated charcoal is used to reduce absorption and increase elimination of ingested poisons. It binds them in the GI tract. It's given, should be given within the first hour of ingestion, but it doesn't work if they've ingested kind of petroleum products, corrosive substances, alcohols, cyanide and metal salts, including iron or lithium, and you should avoid it if those are what you're suspecting. The reason I kind of wanted to bring it up is it's often forgotten, especially if a patient's presented obtunded after immediately taking things, or they've taken a staggered ingestion, they're needing to go up to ITU, and it gets lost kind of in there, and it is worth bearing in mind. Additional kind of decontamination elimination measures, we don't do gastric lavage anymore, but we do sometimes do whole bowel irrigation, and that's the reason that Laxido and Movicol are on the necessary antidotes or treatments list. Whole bowel irrigation is useful if a patient's taken, well, it's one of the LIMPs type things, which is lithium, iron, metal salts, if they're a packer or a stuffer, or if they've taken sustained release medications, especially beta blockers and calcium channel blockers. It's basically giving loads of Movicol by an NG tube until their rectal effluent runs clear. But there may be a role for continuing this or starting this on the intensive care unit. Then finally, I just wanted to touch on screening and tox screens. As I said, we can quickly test for paracetamol and salicylate and ethanol levels in the emergency department, and your point of care testing will give you carboxyhemoglobin and methemoglobin. And then the lab will be able to run drug levels, so they'll be able to check lithium levels, digoxin levels, theophylline, phenytoin, carbamazepine, and then gentamicin and vancomycin, but those are less often poisonings that you see in the emergency department. Otherwise, we can send urinary drugs of abuse or a urinary tox screen. That tends to be sent to a reference lab, and it takes several days to get back. And it may not be useful because it tests for opiates, benzodiazepines, amphetamines, methadone, cannabinoids and cocaine, but usually by the time the result is back, any of those substances that the patient might have ingested will usually be out of their system and they'll have recovered from. So a urinary drugs of abuse screen is less useful in a kind of undifferentiated overdose who's just come in for a kind of bed and breakfast type thing. So I've tried to look a bit at toxicology, how common it is, why it's important from a critical care perspective, mentioned the service provided by MPIS and Toxbase, looked at kind of a basic approach to a poisoned patient, including kind of your classical toxidromes, which are worth having in the back of your mind. I've mentioned a couple of the life-threatening syndromes resulting from poisoning and some of the specific poisonings that have individual management approaches. We've reviewed the toxins that are removed on filtration, looked at sodium channel blocker toxicity, including tricyclics, looked at beta blocker and calcium channel blocker overdose, talked about high dose insulin therapy, showed you which antidotes we have in the emergency department and then in the hospital, looked at charcoal and whole bowel irrigation, and as well as in the elimination side of it, looked at urinary alkalization to aid excretion in the salicylate bit. And we've covered testing and poisoning and what we can test for and when it's useful. It's by no means an exhaustive look at poisoning and toxicology, but I just wanted to try and cover some of the useful aspects for the intensivist who might be going down to the emergency department to look at an overview of management of critically unwell poison patients. The take home for me whenever I'm kind of looking at toxicology is that the mainstay is supportive care, assessing and managing kind of initial airway, breathing, circulation issues, always having a look at ToxBase and seeing what's on there, because it's always really useful information, keeping an open mind and being wary of rapid deterioration. Has anyone got any questions?
That was great, Dan. Really, really thorough, and said it wasn't exhaustive. It was pretty close, I would say. Brilliant. So if you don't have any questions, I think the second bit of this afternoon is a journal club presentation by John, who I can see sat in the Glenfield.
Good afternoon, everybody. My name is Jun. I'm one of the registrars currently in Glenfield. I'll start off our journal club this afternoon with a paper that has asked me to present, but unfortunately it's one that I read before. The title is a recent publication just earlier the month in the New England Journal of Medicine, Balanced Multi-Electrolyte Solutions versus Saline in Critically Ill Adults. Conveniently called the PLUS study because plasma-light versus saline. Everyone finds a nice acronym. This is a good one. On just a little bit of background, why this is important and relevant for us. Fluid resuscitation obviously is a very key component in critical care therapy. It's pretty much something that we do every day, everywhere really. There's always this fluid superiority, particularly within anaesthetists and intensivists versus other parts of the hospital. We like to think we know better. In the past, it used to be on colloids versus crystalloids. There were some studies, for example, in SAFE study looking at albumin, human albumin, some studies against starch. Although not massive, great studies, the SAFE study did show that albumin resuscitation in patients with traumatic brain injury saw an increase in mortality, however, not much difference elsewhere. And hex starch, they all have their own issues, have come and gone and it's come back. Is a bit of a trend, but today we're going to focus a little bit more on crystalloids because what we use more. Saline, 0.9%, obviously is the most commonly administered fluid not only in our critical cares but all over the world. It's used the most, but there are concerns with it, particularly whether it has an increased risk of acute kidney injury, particularly hypochloremic acidosis we have seen, and whether this causes any increase in mortality, particularly in the intensive care and critically ill population. Saline being the most commonly administered fluid all over the world, if there's an increase in mortality, even slight, can be very significant, and it's particularly something that people have and are studying quite intensely about. Balanced salt solution are basically any other crystalloids with a chloride content more similar to plasma. And a great example, obviously, is Hartmann's, Ringer's, Plasma-Light, but anything with sort of with similar particularly chloride content to plasma, and has become much more in trend to do. So here poses a clinical question of this study. In critically ill adults, does the use of a balanced multi-electrolyte solution, for example, Plasma-Light 148, which is what's used in the study as a comparison or intervention, as opposed to normal saline for fluid resuscitation? And their particular focus is whether there's any reduction in 90-day mortality. So trying to find if there's any benefit in balanced electrolyte solutions. But ultimately, it comes down to the old adage, saline versus Plasma-Light, one versus the other, who wins? Alien versus Predator, part 6. There are lots of obviously works done before. I've just listed a few done of sort of similar trials looking at different crystalloids. Basics trials, a large Brazilian RCT that was published again recently last year, that shows sort of no difference, and it's a large trial, 11,000 patients recruited, and essentially showed there's not much difference between plasma and sodium chloride. So there's a very similar trial done there. They have their slight variations in their methodology, but we'll go into that in a bit. The SMART trial was done in the United States in 2018, looking at, again, sort of 15,000 patients recruited, lots of centers, looking at the outcome of death, knee replacement therapy. There was some slight advantages and slight positives for balanced electrolyte solutions there compared to saline. And then you have another more recent study, an older study, sorry, in the split trial, looking at both plasma and sodium chloride again, showing no difference. So lots of things done, lots of different places, lots of different patients recruited. Unfortunately, not very much in consensus. So I think the term they given this was a clinical equipoise. Onto the methodology. This is a double-blinded, parallel group randomized control trial where sort of the block randomized. It was investigated, initiated. There were funding from the New Zealand and Australian MRCs, and some of the fluid were provided by Baxter in identical 1,000 ml bags, where it was literally macroscopically is described identical, so no one could tell the difference. Patients were randomized, and then they were assigned in blocks to receive one therapy, and they received that particular fluid that they were given for up to 90 days after randomization. The treating physicians were able to decide the volume and rate, but they were getting the same fluids when they were receiving a crystalloid fluid resuscitation. Once out of ICU, however, the type of fluid the patients received is not dictated by trial protocol, and that could be within a week or 30 days down the line. So they're more particularly interested and invested in the intensive care patient population as a result. Next slide. There we go. So the data collection was done in, obviously, at initial recruitment randomization, where basic demographics, Apache score, and they also collected information necessary to deduce the patient was possibly have the diagnosis of sepsis, even if it's not recorded. So fantastic. For the first 7 days, intense data collection, they were recording hemodynamic variables, volumes of total fluids given, blood products administered, urine output, organ support, lab data, and data derived SOFA score. And then from day 8 to 90 onwards, so at the end of their period, they also monitor sort of ventilation status, renal replacement therapy status, again, SOFA score. And they're also looking at creatinine levels and the total volume of fluid administered throughout the whole stay in intensive care. So not particularly difficult to do, but very, very labor intensive. And moving on to their outcome measures, what were they measuring? And ultimately, they split this into two different outcome measures. So they have a main primary goal, which is death from any cause within 90 days of randomization. So that was what they wanted to know, whether there's any difference in mortality, one or the other. That's the main goal. Secondary, obviously, we have sort of a list of questions, whether there were any difference in creatinine, whether patients were on renal replacement therapy, any difference between vasoactive therapy and duration, mechanical ventilation, and total length of ICU stay and hospital stay. The primary outcomes sort of death, they also sub-analyzed in 6 groups, just to make it a little bit more even, looking at patients differing in severity, sepsis, AKI, pre-existing, age, sex, and ICU admission after surgery, just to have a little bit more information. So going on to the study itself, now this study was mainly held in Anzac, so within Australia and New Zealand, 53 ICUs, the majority of in Australia, large units, and it was held between September 2017 to December 2020. Patients 18 years or older were recruited as long as they were expected to stay more than 3 consecutive days. They were consented either obtained from patients or their legally authorized representative. The exclusion criteria were whether patients, if they had specific fluid requirements, for example, burns patients, patients with sort of, for example, heart failure, anyone who also received a large, more than 500 ml fluid bolus or resuscitation before randomization were also excluded, and if there was imminent risk of death and life expectancy was less than 90 days. There's a caveat there, patients with traumatic brain injury or risk of cerebral edema were excluded as well, because I think the fluid management prefers saline over balanced salt solutions to begin with. Onto the trial. Initially, the statisticians they employ calculated for the study to be successful with a 90% power. They would require 8,800 patients. However, obviously in the 2019, 2020, COVID-19 reared its ugly head, and a lot of sites had to suspend their research. And ultimately, they managed to recruit only sort of around the region of 5,000 plus patients. So they revised the power calculations, and actually 5,000 patients were conveniently more than enough. And if they did any more, they felt that it wouldn't have made any difference. So hey, moving goalposts worked. So ultimately, they recruited 5,000 patients. They were randomized half and half into balanced salt solution and half into saline. This is out of 16,000 patients screened and 11,000 excluded. A majority of the exclusions were due to the exclusion criteria, and about 1,000 went into the sort of other slash clinician declines enrollment. But there were not many, and they managed to hit their target of over 5,000 patients, and that's quite good. The next slide that I'm going to bring up shows a breakdown of sort of the characteristics of the patients they recruited. As long as the slide loads. Come on. Oof. I don't get why this is so slow. There we go. So the average age for both groups were very similar, 61 years, sort of 62 years old, more men than women, and a mix of A&E admissions, hospital admissions, and patients admitted after surgery, whether it be elective, emergency. And it was felt that their patient population that they recruited were very similar to what all the units that were participating in the trial were expecting. So there's a similar case mix. A large proportion of the patients on both arms of the study were ventilated invasively, mechanically ventilated, so 75%. So these were sick patients, not just passing by. And about 1 to 2% of the patients on both arms received renal replacement therapy at the end. And a little bit more information down in terms of sepsis, which I'm not going to go into at the moment, but they've randomized well, and it looks to be a quite useful split. It's loading. Not sure what I can do to make this any faster, but so on the intervention itself is obviously plasma-light. So what we're trying to look for, plasma-light versus saline. Patients will receive the study fluid, as I said earlier, for their up to their 90 days in ICU, but not more than their stay in ICU. The study fluid itself was used as long as it is as long as fluid therapy was required. Drugs were mixed with 5% glucose when possible to minimize exposure to alternative fluids and salt balances, and I find that very interesting. And if specific crystalloid solutions clinically indicated, they were allowed, but there was a mark on it, and there's another part in the appendix about that. And should they be readmitted within 90 days into ICU, then the use of the study fluid was continued. All other treatment were at discretion of the treating clinicians themselves. Now, after the patients were obviously randomized, over 95% on both arms were given the trial fluid. Mean duration of treatment with assigned fluid was about 6 days on both sides of the trial arm, and the median volume of fluid received on both sides of the arm, both sides of the trial, was sort of 3.9 liters for balanced salt solutions, 3.7 for saline. Again, very similar. And post randomization, this is just a little note. if anyone post-randomization had more than 500 mils of a different fluid than they were allocated, they made a note of it. And there is a difference here. In most patients who had balanced salt solution, up to 63% of them had more than 500 mils of a different fluid infused. So that's quite a lot compared to saline, where if you were on saline, you had about 96.5% chance of just receiving saline. However, if you have balanced sort of salt solution, there's a more than half chance of you receiving more than 500 mils of saline at this point. I find that quite odd, and I don't know whether it could be explained by drug infusions or perhaps sort of preference of saline in dire circumstances, but I've not been able to find an explanation on that, and that's just something that I note. But more than 500 mils total within their stay, that's just something of note. Whether this will mean anything or not, we'll talk about this at the end of this talk. A mean difference in sodium chloride concentration was less than 1.99 millimoles. Again, there's some graphs that I want to show a bit later about that. So on to the results of this, so the main outcome. So in line with the primary outcome, so the main goal of this study was whether any difference in mortality in 90 days between these two. And there are about 530 deaths in each group, pretty much almost exactly the same, 21.8%, 22%, with confidence, absolute risk reduction of less than 0.15% with balanced salt solution. So more analyses sort of were done looking at whether those receiving more than 500 mils of extra fluid prior to randomization, and they were excluded to see if there was any difference. And in the end, they showed that there was actually no difference. So going to the main outcome of this study, there's absolutely no difference in this study between patients receiving balanced salt solutions or saline in terms of their 90-day mortality. Going on to their secondary outcomes, from the list I put earlier, again, unfortunately, nothing much interesting more, but I guess it's interesting to me, but there were no significant differences in patients in terms of needing renal replacement therapy, their receipt of vasoactives, and the time on days alive or free of mechanical ventilation, or even in changes of creatinine. There was actually no difference at all in both fluids. The only difference I found interesting was, obviously we know that with saline and heavy saline use, there is the development of a hypochloremic acidosis, and indeed we can see this in pH of patients receiving saline up to about day 4 or 5, in particular in the acute phase. Their pH was a little bit lower, and of course their chloride was more. So yes, patients receiving more saline do develop more chloride. They do have a little bit more. They're a little bit more acidotic. But all in all, looking at the creatinine, there's no major shift between creatinine in both of them, so it doesn't really cause or worsen any AKI. And we know from the results that there's absolutely no difference in death after 90 days. There's no difference in renal replacement therapy requirements. There's no difference in vasoactive ventilation. So the study authors conclude that the use of plasmolite 148, because that's what they use in the study rather than any salt, compared to saline, does not reduce 90-day all-cause mortality or risk of AKI, which I find very sensible. Now, going on to the strengths of the study, sort of how I feel about reading this. It's a large randomized controlled trial across 53 ICU, 2 countries, with a very similar patient population, obviously, to ours here in the UK. The protocols for randomizations were very good. They were very upfront about what they were doing. I feel that this is a very reproducible study should we want to run anything. The methodology were very clear and a bit labor intensive, but definitely doable. They've pre-published their plans as well in the early 2019, 2017, particularly with the changes of COVID in 2020 as well, about their statistical analysis and the intention to treat analysis, or open for critique, and they made changes appropriately. They were very transparent about it, and they have very good 96% follow-up up to day 90. The patients were unwell. They weren't just sort of post-op elective surgical patients, come in, have some lunch, stay for a few days delirious and go home. More than 3/3 of them needed invasive mechanical ventilation. They were very equal in both arms of the trial. Some of the previous trials sort of split down the basic splits. There were sort of almost half of the patients were from elective operations, and in this one there were much better sort of proportion and similar to what we would see in a large tertiary centers ICU workload, or even in the DGH really. Larger volumes of trial administered compared to other trials, up to nearly 4 liters in about 6 days compared to less than 3 liters in most of the studies. So those are the strengths of the study I felt. So they make a very convincing argument. But in regards to what they could do better in the weaknesses, obviously with COVID itself, it's unavoidable that they were having to reduce their recruitment size, but they did their analysis and they felt that this is more than enough. If they were to do more, it wouldn't have changed the outcome. Fair game. I don't understand their statistics as much as they would, so I would do a bit more reading if I could, but in terms of power calculations, it always goes over my head a little bit. There was some protocol deviations, as I said earlier, about 63% receiving balanced salt solution had more than 500 mils of another fluid chucked in, and obviously there were no records of how much extra this was, where it just coincidentally we have an extra liter built up over the days from medication or whatnot. It wasn't clear. This may result in some contamination. It's hard to say. I will give it a pass on that. I'm sure there are some reasonable explanations, and the authors have gone on some podcasts from critical care reviews. I've not yet listened. I'll be curious to see what happened, but I'm sure it's nothing unreasonable. And the other thing I felt was a bit shortchanging was most of the fluids were not controlled or recorded once they leave ICU at all. And I've not seen a record of how many patients are readmitted as well afterwards and continued on the trial fluid after a period lounging on the wards. In my conclusion, anyway, compared to the authors, I think it's a high quality, large RCT trial showing that saline does no harm. And lots of studies, the meta-analysis recently all come out sort of supporting very minimal differences between both. And even then, I think if there were any sort of with something so large as just saline use, any small increase or reduction would be significant, but they couldn't really find very much. And in terms of how this reflects on my practice, I think I will, as a clinician, continue to use balanced salt solutions. But if someone gives me a bag of saline, maybe an A&E and theater, and I need it, I wouldn't say no to it. I know it wouldn't make any difference, and I sure wouldn't make much more of a hassle about it to my colleagues elsewhere as well. So that is the end of my talk. Can I open the floor to any questions? It's a good study to read up. It's probably going to use for convincing argument. Yeah, in the Royal.
Okay, brilliant. Yeah, no, my comments really is, I mean, 4 litres of fluid over, was it 6 days or 4 days? I can't remember now. What was it? It doesn't sound like a loss of fluid, which I get is better than the other studies that you mentioned. And also in the, you quite rightly mentioned about the plasma-like group, 63% having more than 500 mils of other fluid. When you're looking at an average of 4 litres of fluid, if they've got more than 500 mils of another fluid, it's over 63%. I think it's quite a significant problem in the study. I mean, do you agree? Or
I actually don't see it. The days alive outside ICU, 63, 65. Days alive. Have they actually not recorded this down for me? I actually don't see. Actually, I didn't think about this the other day when I was doing this. I actually don't see any record of the total length of stay in ICU. I don't think they talked about this as well in the discussion. have a deeper dive in a bit about this, Alex, but I actually don't think there's any mention of this total length of stay. They've only made a note of days alive outside of ICU. That was awkward. Good to know, actually. Anyone else got any idea?
I mean, my feeling is if it did show that there was quite a significant difference in acidemia, you might be more reluctant to discharge somebody from the ward if they're a bit more acidemia compared to other patients. And that makes a massive cost effectiveness of using IV fluids when, you know, if the length of stay is different between the two groups, then obviously that's a massive.
I'll get back to you, Kishan, about this.
This is a comment, really, that's all.
In the meantime, does anyone else have anything else to add?
Is Matt still there?
Can I ask a question to the group if there's no other questions at the moment? So if sort of following this study, it seems to show no difference, and you're given the choice between a bag of saline or a bag of balanced fluid, what's everybody's preference?
I think there is a note on situation. For example, if your patient particularly is going to be at risk of worsening in terms of acidosis, like TKA, or if they're already loaded with sort of hypernatremia, then obviously I would try to go for the balanced salt solution. But saying that if you're starting from sort of like she said, clinical equipoise, where both would be fine, that's a harder question.
Would anyone here?
For the first few days, there is a slight less pH.
Would anyone here preferentially choose saline over balanced solution? Raise your hand now.
Forever hold your peace. I would still go for normal balance.
I think you hit sort of hit a nail on the head, haven't you? In terms of, you know, you use your fluid to the individual patient in front of you, and that's one of the major issues with a lot of these studies, isn't it? Is the fluid use is very dependent on the physiology that you're. If you've got somebody who's got massive energy losses and losing a lot of acid and a lot of chloride, then yes, saline is definitely the first line choice. But
Alex, sorry, I can barely hear you.
Okay, sorry. I'll shut up.
That's rant as well. I think we'll probably sort of draw everything to a close there, really. June, really well presented, and really good deep dive into the paper itself. So thank you very much for that. If you have a look in the meeting chat, you should have the QR code for feedback, which I don't know if I can share that. But if you have a look in the meeting chat, you should have the QR code for feedback. If you could scan that, that would be great. But yeah, thank you all again for attending. I'll leave it.
Thank you very much, everyone.
I'll leave things open just for a little bit longer for people to scan that QR code.